Good afternoon, everyone. A lot of familiar faces. It's my pleasure to introduce Dr. Alan L. Ho. Dr. Ho is a medical oncologist at Memorial Sloan Kettering Cancer Center in New York City, New York. He specializes in the treatment of head and neck malignancies, specifically cancers of the salivary glands and thyroid. Dr. Ho did his residency at Weill Cornell, New York, Presbyterian, and fellowship at MSKCC. Welcome, Dr. Ho.
Thank you. So thank you so much for the honor of being here today. Welcome to the people in the room. Welcome to the people on the webinar. So what I wanted to do in this session was kind of talk about the treatment of really the most challenging parts of this disease. You know, the patients who have incurable radioiodine refractory differentiated thyroid cancers and anaplastic thyroid cancers. And specifically, what I want to do is kind of tell you about a clinical trial we're developing or trying to execute now, where we're taking a different approach to designing that trial to try to get at quicker answers for what drugs work and don't work for these patients. And so what I thought I would do as part of background is to kind of give you a very brief overview of where we are in terms of therapeutics for these diseases, and then how that leads into the trial that we're trying to do. And the different kind of aspects to that clinical trial. Okay. So, I mean, all of you are very sophisticated about this disease, having dealt with it yourself personally or in your family members, but just to kind of orient you to what we're talking about today is, you know, thyroid cancer is made up of actually a lot of different cancers, and specifically by where it originates. So the most common ones are the ones that originate from the cell in the gland that's called the follicular cell. This is the cell that creates thyroid hormone for the body, okay? So the cancers that arise from the follicular cell include papillary thyroid cancers, which is 80% of the disease, and then to lesser extents, follicular cancers and Hürthle cell cancers, which are, you know, smaller percentages of the disease. And then what's also part of what we're going to talk about today is anaplastic thyroid cancers. And at least what our understanding now is that these anaplastic thyroid cancers are just more aggressive variants of these more common differentiated cancers. I also put this up here to start just to kind of orient you not only to the disease that we're talking about, but the different ways that we treat these diseases and the different clinical scenarios, right? So the most common scenario at initial diagnosis is patients that come in just with a cancer in their neck, hasn't spread anywhere else. And of course, we treat those patients with surgery and sometimes radioactive iodine and then watch them. What this trial and what the treatments I'm going to be talking about are focused on the patients whose tumors either come back or spread to different places, particularly below the shoulders. In those situations, we call those distant metastatic patients, okay? And the reason why that's important is because we have a lot of effective treatments for this group of patients, but typically the treatments themselves are not curable, meaning we can control and shrink disease, but we can't eliminate it completely. So there are two categories of this kind of incurable subset. One is we call RAI-avid. What that simply means is that radioactive iodine can be used to treat these patients. Okay, so you can see this scan here. This is a patient with lung metastasis in their lungs, this black stuff. So these are tumors that are soaking up the radioactive iodine. You can give this patient radioactive iodine, and hopefully that radioactive iodine goes to those tumors and kills those tumors and shrinks those tumors. So this is in RAI-avid patients. The most challenging patient to treat, though, is RAI-refractory. Okay, so whether cancers start out this way or they develop resistance in this way, you can see a similar patient. This patient actually does have lung metastases, but you can see in the scan you can't see it. And the primary reason you can't see it is because it's not soaking up the radioactive iodine. These tumors have found a way to not take up radioactive iodine. So you give this patient radioactive iodine, these tumors will not respond. So this is really the category of patients where a lot of drug development has focused on. Drugs like lenvatinib or sorafenib and cabozantinib, drugs I'm sure you've heard of. And it's really going to be that's going to be the focus of the problem that we're going to be talking about today, both for treatment of RA-refractory thyroid cancers and also anaplastic thyroid cancers. Okay. So I said most of this already, and just to highlight again, over the last 10 years, maybe, well, 15 years now, it's really been a boon in treatments and trials for these patients, leading to the FDA approval of 3 drugs, the ones I mentioned. And even though it sometimes feels like we're hitting a lot of singles, over the last decade or so, those singles have really manifested into actual effective treatments for patients, whereas in the last several decades, there was absolutely no drug development available. But I will say that these drugs all are similar in that they're in the same class. Okay, they're called tyrosine kinase inhibitors, or TKIs. They hit similar targets in the tumors. They have similar side effect profiles and similar efficacy in some ways. And they're applicable to all radioiodine refractory and curable cancers. So in one way, that's good, but it's different from the next category of drugs that I want to talk to you about. So before we get to that, just as a kind of mantra, so you have these patients that have distant metastatic disease, and we're talking about RAI-refractory thyroid cancers. It is still true that this can be a slow-growing disease, okay? So when we see these patients in clinic, our first thought is not, what are we going to treat the patients with, but do they need treatment, right? Because some patients can go without treatment for months or even years, where their tumors may have spread, but they're not growing, or they're growing slowly. And so that time that you can get patients through and they're feeling well and not needing treatment, that's a big win, right? Because we don't want to expose patients to treatments that they don't need. And even though the drugs that we've developed can be effective, they have side effects, so that risk benefit is always in mind when thinking about whether to treat patients or not. And in the end, the basic paradigm that we use is if the tumors are growing or you have tumor-related symptoms, then it's time to think about the drugs. But of course, even in that definition, you can see how broad that is, right? There's a lot of clinical judgment that goes into that. And indeed, you might see variance in the way one oncologist treats patients from another, because we all kind of have our different nuances in how we assess what progressive disease really means, okay? What we need are metrics, quantitative metrics that says, okay, if your tumor grows to this degree or at this doubling time, this correlates to survival, and then we know this is the time to treat you. We have incremental progress getting there. Pictured here is Mona Sabra and Mike Tuttle. These are well-recognized endocrinologists at Memorial that has worked on this problem by looking at scans of multiple RAI-refractory thyroid cancer patients. Okay, so we're getting to the meat of what I wanted to talk about today. So we've got all these effective drugs with different kinds of TKIs. But the one thing is there's a little bit of biology here, and listed here is a series of genes that are all connected, okay? And the reason why these genes are important is because they all work together and regulate each other within thyroid cancers to make thyroid cancers grow and survive. And this whole pathway is called the MAP kinase pathway. The reason why we know this is important in thyroid cancers is because in over 70% of thyroid cancers, over 70% of thyroid cancers will have a mutation in one of these genes, okay? So when you see that as a biologist or an oncologist, you know that that pathway is important, that this cancer relies on this pathway in some unique way. Okay. And I'm sure one of the genes I'm sure you've all heard of is BRAF, right? So about half of the patients with RA-refractory thyroid cancers will have a mutation in BRAF. But it turns out that if you don't have a BRAF mutation, there are other genes in this pathway that may be mutated and do similar things to BRAF. The next most common is RAS. Okay, so you can see it's right above it. RAS actually regulates BRAF. And then the other smaller percentage are these receptor tyrosine kinases known as RET or TRAC or ALK. So even though when we sequence patients, we see these genes come up on their profile, biologically, we know they're connected. RET activates RAS, which activates RAF, which activates MEK, ERK, and then the proliferation of survival signals, okay? So what this is telling you is that in over 70% of thyroid cancers, RAI-refractory thyroid cancers, they want this pathway activated to survive, whether it be through this gene, or this gene, and a few others, okay? So that's nice to know biologically, but when we know that biologically, the next thought is, well, if the thyroid cancers are so dependent on this pathway, they're so dependent upon these genes, couldn't we design drugs that block these signals and hence use them as effective treatments? And of course, I think some of you know the end of this, which is that there are a variety of different drugs that have been developed against different nodes in this pathway for this very reason, not only for thyroid cancer, but for other diseases where these genes are involved, like melanoma. Okay. So probably among the two most effective are inhibitors of these RTKs very recently, where they've developed really effective drugs with amazing major response rates with drugs like selpercatinib, pralsetinib for RETs, or larotrectinib and entrectinib for NTRK, okay? And then an older class of drugs, but also very effective, are these BRAF inhibitors. So if you have a BRAF mutation, it would make sense to treat you with one of these BRAF inhibitors. And then there's data that if you combine the BRAF inhibitors with these inhibitors of MEK in BRAF mutant patients, you get even a better effect, okay? And we're gonna go through a little bit of these examples in a second. So I'm just going to go through this very quickly. This is that selpercatinib in RET mutant thyroid cancer patients to illustrate how effective these drugs can be. Now, just to orient you, what these graphs, I'm going to show you a lot of these graphs, okay, and they're all the same. Each one of these bars represents a different patient treated on a trial, okay? And what these bars are representing is when the patient went on the trial and got the drug, what was their best outcome? What was the maximum shrinkage they achieved on that drug? So you can see the x-axis here is 0, right? So these two patients, they had 100% shrinkage of their tumors. They disappeared, okay, on this particular drug. When we say response as oncologists, oftentimes you'll say, wow, this is really active. There's a high response rate. What we're technically really saying is the percentage of these patients that had 30% or greater shrinkage as their best response. So that's why whenever you see these plots, there's this dotted line here. That's the 30% mark. So all these bars below this count as major responses, okay? So you can see in this particular trial, 79% of patients had a major response. And of course, you can see 2 patients who had 100% response, which is fantastic. And then these are other categories of tumors, but this was the RAI-refractory group. This is for NTRK, another rare rearrangement in differentiated and anaplastic thyroid cancer. Same waterfall plot. They don't have the dotted line, but here's 30%. And you can see, again, really high rates of response, about over 80%. Okay. So if you have the right drug and you apply it to the right tumor with the right mutation, you can get these kinds of responses. But we're not so lucky that we have that for every mutation, whether it's the drugs are not as good or the mutation is hard to target with a drug, which we'll talk about in a second. So this is the BRAF data. So the first BRAF inhibitor that was developed is called vemurafenib. And this was first approved in melanoma. So this is in BRAF mutant thyroid cancer patients, RAI-refractory, incurable patients, and their best response. And you can see, first of all, everybody had some kind of shrinkage, right? But that major response rate was 35%. That's okay. That's good, right? But it wasn't the 80% we just saw, right, with those other drugs. But still, an effective treatment for these patients. That was in patients who had never received a drug before. These are patients who may have been on, let's say, sorafenib, was on it for a time, didn't do well, progressed, and now we put them on vemurafenib. Again, you can see patients shrink, but the major response rate's a little bit lower. And actually, the other measure we use here is progression-free survival. What this means is how long were the patients on the drug before their tumor started growing again? And that's shorter. So we know that these patients are not as responsive to these drugs if they've been on another drug before. That's actually a common principle you see in oncology usually. This is that same data I just showed you. 38%, or it was actually 35%. There was different reports, but we'll go with 38% in the treatment naive patients and 27% response rate in the patients who got some treatment before. And as I told you in that other graphic is we now know that if you combine a BRAF inhibitor, will this show up? Actually, and a MEK inhibitor together, that's what dabrafenib is, a BRAF inhibitor, trametinib is a MEK inhibitor. If you put them together in melanoma, it's better than the BRAF inhibitor alone. Well, there was a phase 2 trial that was done through Ohio State, MD Anderson, the International Thyroid Oncology Group, and they compared the 2 drugs versus the 1. And our surprise was that the response rate was actually quite similar. Okay. But if you looked at how long disease was controlled for, it trended to being better with the 2 drugs. So a little bit of an interesting result. But still, the general principle is the same. If you have a BRAF mutant tumor, it may respond to a BRAF inhibitor. Okay. We want to transition a little bit and talk a little bit about anaplastic. Okay. So as I mentioned, this is not a static disease. Thyroid cancer is not a static disease. You can start with a differentiated cancer, like a papillary thyroid cancer or a follicular thyroid cancer, and over time, it can get de-differentiated. What that means is, when you're a differentiated cancer, even though it's cancer, if you look at it in the microscope, you can kind of tell it came from the thyroid lobe. Why? Because you can kind of see the architecture of the thyroid lobe, but it's a little bit more disorganized. When it becomes less differentiated, it's starting to lose the characteristics of the thyroid. It's starting to look just like sheets of cells, okay? Anaplastic is the most de-differentiated form, okay? So anaplastic doesn't look like the original thyroid at all. And you can sometimes see this transition within one tumor, where there are parts of it that are papillary, that they look more poorly differentiated, and then anaplastic. You can almost see the tumor transforming, in one specimen. What's also associated with this transition is the genetics of these tumors change. So these differentiated tumors are much more simple genetically. There's only maybe 1 or 2 genes that are mutated. By the time you get to anaplastic, it could be 10, it could be 20, okay? So what that tells us is that this transition from a differentiated cancer to a poorly differentiated to a de-differentiated cancer is accompanied by or caused by the acquisition of new mutations, okay? And it turns out that this disease is very different from this disease, even though they have some similarities. And the way they respond to drugs is different. Lenvatinib is an approved treatment for differentiated and poorly differentiated thyroid cancer based upon a phase 3 trial, right? But a phase 2 trial of lenvatinib in anaplastic was negative. It failed to show benefit. So it just shows that even though they're connected and they're genetically connected and biologically connected, it actually behaves differently. And this is a much more aggressive disease, of course, and doesn't respond to the same drugs that these cancers do. Okay, so it's important to know what is anaplastic and what isn't. Another illustration of why these things are different, okay? So you actually get different outcomes with BRAF inhibitors, whether you're talking about the differentiated cancers or the anaplastics. These are the numbers I just showed you in that randomized trial where the response rate with the 2 drugs versus the 1 drug was the same, right, in differentiated cancers. But look what happens when you give that same combination to anaplastic patients. You get a 56% response rate versus 30, okay? This was a very surprising observation. These are the waterfall plots. This is the differentiated cancers, this is the anaplastics. Look at how deep these responses are, okay? This was a very surprising result because typically, as I mentioned with lenvatinib, anaplastic is much harder to treat and are not as responsive to differentiated. This is probably the first example where that was not the case. And now we're thinking that maybe the reason why that is because these drugs, even though they're the exact same drugs and they hit the exact same targets, they work in different ways in anaplastic to get better outcomes than we do in differentiated even, okay? And but more pragmatically, what was so exciting about this result is the fact that this is a universally devastating disease where patients' mortality is measured in months. And this, look at this, 43% of patients didn't have tumors grow in a year on this drug treatment. Okay, that is an unheard of result. So this was really a major meaningful step forward in developing treatments for these patients. So interesting in that we have to figure out why was this so different in anaplastic, because that will help us develop other drugs, right? And also help us improve why these drugs don't work as well in differentiated. But also, it just proves that targeting MAP kinase pathway BRAF in anaplastic can be a really effective way to go. Okay, and we need to find different ways to do that for even the non-BRAF mutant anaplastics. Okay. So as I mentioned, all the FDA-approved drugs right now are TKIs like lenvatinib, sorafenib, et cetera. Dabrafenib, trametinib for anaplastic was the first MAP kinase pathway inhibitor approved, right? Specifically for thyroid. The other reason why it's important to think about MAP kinase pathway inhibitors is because they can also be used as treatments for thyroid cancer patients in more than one way. Okay, so everything we've been talking about so far is, okay, if we give the drug, does it shrink the tumors? Okay, and that is classically the outcome for 99.8% of all cancer trials, with obvious reasons. And that's what these waterfall plots illustrate. But it turns out that these drugs can not only shrink tumors, but remember that patient whose tumors don't take up the radioactive iodine in the lung, okay? It turns out that some of these patients, when you give them a BRAF inhibitor or you give them a MEK inhibitor, these tumors now take up radioactive iodine. Okay, this is a MEK inhibitor on one of our trials. So you see this other patient, this is the lungs. This is kind of cut through. This is a CT scan where the patient's body's cut through here. This is the heart, this is the chest, this is the back. And here's the lung fields. You can see some of the tumors are already take up radioactive iodine at baseline, but after the MEK inhibitor, it takes it up more intensely, and then there are new tumors that didn't take it up before, now takes it up. This doesn't happen in 100% of patients, but we've done a number of different trials. We and others have done a number of different trials trying BRAF inhibitors, MEK inhibitors, and RET inhibitors, and it happens in a subset of these patients. And then you give these patients radioactive iodine, and you can shrink the tumors again with radioactive iodine, okay? This is a phenomenon that is limited only to MAP kinase inhibitors. It doesn't happen with lenvatinib. It doesn't happen with sorafenib, okay? So in addition to directly shrinking tumors, could you also develop these drugs for this purpose, right? And the last one is one I talked to you about with anaplastic, okay? And it turns out that the reason we think the BRAF inhibitors work so much better for anaplastic is we think that it actually doesn't directly shrink tumors in the classical way. And this is just a hypothesis that we're still trying to prove, but that maybe one of the reasons why it works so well is because it's actually activating the immune system to see the tumors better. So by inhibiting MAP kinase pathway inhibitors and pathway activation in anaplastic tumors, we're actually activating the immune system to attack the tumors. And these are just some example in our mouse models where this is happening, where we turn off BRAF activation in an anaplastic mouse model, and these macrophages, these brown spots, which we know suppresses the immune response, are now depleted. And then in its place is infiltrated by activated T cells to attack the tumors, okay? And we think that this phenomenon exists because the immune environment of the anaplastic is distinct from differentiated thyroid cancers. So another application, potential application of MAP kinase pathway inhibitors is in the right environment, they could potentially be used as immunotherapies, all right? And indeed, MD Anderson is combining dabrafenib, trametinib with immunotherapy for this reason, okay? So going back to this schematic, we talked about the fact that we've got a lot of effective drugs at different nodes, right? But what's obvious is that not every one of these nodes has a drug associated with it. And indeed, what has really been challenging is that patients with the second most common mutation in this pathway, which is RAS, doesn't have a targeted approach for it. Well, you could say, well, we could use these MEK inhibitors since we're all signaling down in the same direction, right? Can't we just block the signal with MEK inhibitors? And indeed, that's been tried in a clinical trial and it was negative, okay? There are a variety of biologic reasons for why this is more challenging. And the other issue is the gene RAS itself, it's really hard to develop drugs that target it directly for biologic reasons. It's not like BRAF or MEK. There is one mutation that's been really well targeted with a specific drug, a G12C mutation in RAS in lung cancer, but that's not relevant for thyroid, unfortunately. So if we want to target RAS, we need to find ways to do it in indirect ways. The other reason RAS is really important is because it turns out that RAS mutations can be acquired by tumors that are treated with these other inhibitors as ways to make them resistant. So if you get selpercatinib in a RET mutant tumor and you're on it for 2 years and all of a sudden the tumors start growing and then we biopsy again and look at the mutation, it turns out they now have a RAS mutation. So you can see because of this linear pathway why that RAS mutation would mediate resistance. You might be inhibiting up here, but if you've got a RAS mutation signaling down here, it's not going to affect it, right? So another reason why for patients even that have effective treatments, that finding ways to inhibit RAS are going to be important. And this is what the trial that we're doing is trying to accomplish. So as I mentioned, we've been trying to do this with these MEK inhibitors and really with little success. Admittedly, there are more trials that should have been done with these drugs that haven't been done, but the ones that have been done have not been very promising. So the trial that we are developing, or just activated now, is with a novel MEK inhibitor. It's called avutometinib. We've been aware of this inhibitor now for over 10 years. It was originally developed by a Japanese company. One of our close collaborators, Jim Fagan, who has mice that had thyroid cancers, he would treat those mice, whether they had a BRAF mutation or a RAS mutation, with this drug, and by far was the best performer of all the drugs that we've tested. Unfortunately, Chugai at the time was not interested in developing this in thyroid cancer. There were issues with toxicity. They were developing in lung cancer and everything else. But it's been recently acquired by Verastem Oncology over the last several years and has been developing this drug and found a new tolerable schedule for it. And of course, that reawakened an interest in thyroid cancer. And the reason why we think it works better than these MEK inhibitors is based on data that was published almost 10 years ago now, where they figured out that the reason why this drug works better is because it not only inhibits MEK, but it actually inhibits BRAF at the same time. So that 2-drug combination I showed you with dabrafenib and trametinib, it's actually recapitulated in one drug for a novel mechanism, okay? So we think that the reason why this works so well is because it inhibits BRAF and MEK. And one of the things that we want to test is if it inhibits these 2 nodes well, is inhibiting 2 nodes better than 1 when we're thinking about RAS, okay? And other mutations like it. So this is a diagram that was developed by Verastem. And what it illustrates is a little bit of the same thing that I just showed you. This is that MAP kinase pathway. This is avutometinib that inhibits RAF and MEK at the same time. So they've been developing this drug in lung cancer and specific subsets of ovarian cancer that are RAS driven, okay? And what they found was, yes, it can induce major responses in those tumors with RAS mutations, but they also found that another gene called FAK, F-A-K, that's up here, can be activated when you give in the tumors when you give the drug. And then when you give a second drug called defactinib, whether it's in patients or in mouse models, you do these 2 drugs together and block this signal, you can drive the signal down and you get better responses. They did a randomized trial in ovarian cancer where they compared this 1 drug alone to these 2 drugs together. And in the RAS mutant group, as well as in the RAS wild type group, both groups actually, the combination was better than the single drug. Okay. So the model now is they're thinking that RAS mutant tumors, if you inhibit both these 2 nodes and FAK together, you get a better clinical outcome. Okay. In thyroid, oh, and this, I forgot to mention, this led to an FDA breakthrough designation for this combination, ovarian cancer. Okay. Now, we can't just assume that the same is true for thyroid, because we have plenty of examples where a targeted approach in one cancer doesn't translate to the same outcomes in a different cancer. They're different cancers. So we have to test this in thyroid. there's reason to believe that FAC is important to thyroid. You can find it activated and expressed in thyroid cancers. There was indeed already data from the University of Colorado, showing that FAC activation can mediate resistance to MAP kinase inhibitors in different ways. So that data was always there. It's just not something that we recognized before. And then when this data came out in ovarian, the question became, should we just test this combination in thyroid cancer? So now that we've got this observation in ovarian, what are the questions about this combination of thyroid? Well, how well does it work? Does it directly shrink refractory thyroid cancers? Anaplastic thyroid cancers have the same mutations, right? Does it work against anaplastic thyroid cancers? The dabrafenib trametinib combination that works so amazingly well, which was such a major advance, is only applicable to anaplastics that have BRAF mutations. That's only 40% of the disease, okay? The rest of the anaplastic thyroid cancers without BRAF mutations don't have active treatments and are just as aggressive and just as deadly. So can we use this combination in those tumors, okay? Can it be used for redifferentiation? I showed you those RAI scans. Well, if we're inhibiting this pathway better, and we're inhibiting mechanism of resistance to those targeted therapies, by definition, maybe we restore more radioactive iodine sensitivity to these tumors. And just like the BRAF inhibitors, can we use these drugs to activate the immune system to attack anaplastic thyroid cancer specifically? We don't know, maybe it's applicable in papillary, but that's just never been demonstrated. So this is the trial. So typically, when you have this number of questions, you do one trial to answer each of these questions. But of course, it's the best and most methodical way to go about it, but that would take decades to answer all these questions in separate trials. So what we wanted to do was try to answer as many of these questions as possible in a small pilot trial that would then allow us to decide what is going to be the best direction to take this. And establish it so that we can get it approved as a treatment for more patients, right? So this is the trial that we decided to do. So we're going to treat two different groups of patients. The first group, cohort A, is in the RAI-refractory differentiated thyroid cancer patients, okay? See, these are the non-anaplastics, because as I mentioned, these are different diseases. We have to assess them in different ways. The second cohort, cohort B, is anaplastic thyroid cancer patients. Okay, so we're going to assess this combination in these two groups independently, okay? Because we know that as we saw with the BRAF inhibitors, you can get different outcomes. And we're only going to limit it to these patients that have these mutations. These are the non-BRAF mutations that I talked about that work in a different biological way. These are the mutations that don't have a MAP kinase inhibitor that can be applicable or developed for it to date. Okay, so it would fill a huge need. The other tumors are the ones that are BRAF mutant and already can be treated with the BRAF inhibitor. So we're going to take those patients with those mutations and these diseases and treat them with the combination. Okay, and on a clinical trial, the treatment principles are the same as off a clinical trial, which is that you continue that treatment, you assess response, you assess how well patients tolerate it, and if it's working and patients are tolerating it, you continue it in an open-ended fashion. Okay, that's true for lenvatinib, it's true for dabrafenib, it's true on the clinical trials. So you get these tumors, and then the primary endpoint, the primary question we want to answer is, does it shrink tumors? The same classical waterfall plot that I've been showing you for every one of the trials. And to do that, as I mentioned, we do the scans before you get the drug, then every 2 months, and then after 6 months, every 3 months. So you're continually assessing response, and you do that for both of these. And you answer the question, do these drugs actually shrink these tumors in differentiated or anaplastic thyroid cancers? And as I mentioned, you do that until the tumors start growing again, or there are other potential reasons why you would stop. There's toxicity that you can't manage with reducing the dose or holding the drug. Patients don't want to be on the trial anymore for any reason. Of course, they are. This is always with their consent. or the physician feels like it's not in the best interest of the patient to be on the trial. The second question, redifferentiation, is also going to be answered on this trial because we're going to have patients also undergo RAI whole body scans before the drug and after the drug. And we're going to compare. We're going to do that same comparison I showed you in those examples between those two patients and say, okay, after being on the drug, are there tumors that didn't take up radioactive iodine before that now take it up? Okay, and so we'll be able to record that data. And then in the patients where we do see new RAI uptake with the drug, we're going to give patients the option to be treated with radioactive iodine if the drug is not shrinking their tumors. Okay, so this would be a way to say, okay, in the percentage of patients where we're not getting really good tumor shrinkage and they have evidence of redifferentiation, can we give them radioactive iodine as an alternative way to give them tumor shrinkage? Okay. So just based upon this design, by doing the scans, doing the iodine scans, and giving this option for I-131, you answer 2 questions from MAP kinase inhibitors in one study. And then the third and last one is the more difficult one, which is the immune activation. The only way to really assess this is through biopsies, okay? So what we've been able to do on our different trials is take patients and do a biopsy before they get the drug and while they're on the drug and compare the immune microenvironment of their tumors and see differences there. These biopsies are mandatory, but of course, patients are exempt if there's a safety issue, if the tumors are not accessible. And this first biopsy can also be skipped if there was a recent collection of tumor that we can use to take its place. Okay, but the reason we're doing this is because of that third question. Does it activate the immune system? Because if we found that it does, then the next trial may not be just doing this doublet, but maybe adding immunotherapy. Okay, so that's the basic design of the trial. So this is what I was saying about the biopsies. They're mandatory unless it's not safe, unless we have a recent tissue that's been acquired that can be used in the place of that first biopsy, if it's not accessible. And the last one is, if you have only one tumor that we can assess for response, then of course we're not going to manipulate it or biopsy it. I'm not going to go through this in detail, but this just illustrates that the primary objective is to look at shrinkage. So that statistically, the trial is powered to answer this question. But the redifferentiation question and the immune activation questions are incorporated as secondary and exploratory endpoints, right? So in a clinical trial, you have to choose one objective to really measure and power it, but we're using these secondary and exploratory objectives to answer multiple questions in the trial. This is confusing, but remember I told you one of the main reasons why this drug wasn't originally developed in thyroid cancer was because they were struggling with tolerability of the drug. There was a lot of diarrhea and other GI issues. What Verastem went to was they discovered that you could get activity or efficacy with this drug and make it more tolerable if you only gave it twice a week. So these are pills. These are oral pills that you take. So on the trial, you take it twice a week for 3 weeks in a row, and then you get the last week off. That's a 4-week cycle. The defactinib, that's the FAK inhibitor, actually is pretty well tolerated. So you get the defactinib twice a day, every day for 3 weeks in a row with a week off. Okay. So this is the regimen that was proven in ovarian cancer to be better than the avutometinib alone, and was found to be tolerable. Now, when you talk about side effects, the things that they have seen are consistent with what has been seen with other MEK inhibitors. Rash is the biggest one, okay? So there's an acne-like rash that happens with MEK inhibitors that the intensity and incidence can be decreased by prophylaxis, whether using antibiotics or using steroid creams. And there's a whole prophylaxis regimen that patients are on to decrease the intensity of the rash. CK elevation is about the muscles and is something we follow in the blood work, but typically does not manifest into clinical symptoms, but we see elevations. The other big one is vision. Okay, so patients with the first dose, a couple of doses of atumelnant will sometimes complain of blurry vision that resolves. That's fine. But the more severe one and the more infrequent visual issue is with the retina. And this has been seen in all MEK inhibitors, where sometimes you can get retinal detachments with the drug. So patients who go on this study can't have had a history of retinal detachments. They can't have a history of retinal issues at all. They have to be examined by an ophthalmologist, and we continue those exams on the clinical trial. If those retinal detachments occur, oftentimes they're reversible when you stop the drug. But of course, we take that very seriously because it's people's visions, right? Then diarrhea, fatigue, and edema are other things that we'll be looking out for. And this is I'm just showing you what's on the consent form and how these things are listed. The way that consent forms goes for patients to read is they divide up all the potential side effects by common. That means more than 20 per 100 may have them, versus occasional, which means between 4 and 20 out of 100 patients may develop it. And then they include the serious ones as well, okay? And I'm not gonna read this list to you, but just to give you a sense of how these consent forms look. And defactinib, you can see that the list is much shorter, okay? This drug is generally better tolerated. It's really about nausea, diarrhea, and fatigue, usually with this drug. I'm not gonna go through this, but I wanted to show this to you because on the clinical trials, just as in regular practice, if we run into side effects, there are manipulations that we can try, which is to reduce the doses of the drug or skip doses of the drug. Because in the end, the safety and tolerability of these regimens are just as important as how well they work, right? So in a clinical trial, the protocol mandates that physicians follow these guidelines for the protection of patients. So we grade each side effect that a patient has, and then there is an algorithm for what you do for that side effect, whether it's to reduce the dose or what have you. In order for a patient to participate in a trial, they have to be eligible. That eligibility is a long list of things that physicians have to go through. I'm not going to go through all of these things, but the bottom line is you have to have the right tumor, you have to have the right mutation, you have to meet definitions of RAI refractoriness, and you have to have tumors of a certain size that we can follow. And then we do blood work and other evaluations to make sure you're healthy enough. You know, that your kidney function is good enough, your liver function is good enough, your marrow function is good enough, your heart is healthy. Because obviously on an investigational treatment, we want to make sure we're not putting patients at excessive risk. We also have to exclude some patients for different reasons, for safety reasons as well. So patients who have brain metastases that have not been treated with radiation or surgery cannot go on. They have to get those treatments first. If they got the same similar type of drug beforehand, well, we don't want to put them on this trial because we don't know how well they'll respond. And then the one specific one here about that blurred vision thing is listed here. So if you have a history of glaucoma or retinal vein occlusion or other kind of retinal issues or uncontrolled hypertension or diabetes, because of the retinal risks to the drug, we're excluding those patients for safety reasons. So I think this is my last slide. So in summary, in RAI-refractory thyroid cancer and anaplastic thyroid cancers, as I said, in the last 10 to 15 years has been a very fruitful time for developing and identifying new treatments for these diseases. Part of those treatments are MAP kinase inhibitors, but they're really relegated to BRAF inhibitors or RET and TRAC inhibitors. And that leaves out probably about 30 to 40% of these diseases where they don't have MAP kinase inhibitors. And the reason we need to develop and find those treatments is because we can not only shrink the tumors, but we can maybe redifferentiate the tumors and maybe even activate the immune system. So finding ways to do that is important, and is why we're doing this particular trial. This combination has shown promising activity in other tumors, but we have to prove it in thyroid cancer because we can't assume that that's going to be the case. We don't know for sure if that's really going to be the case. We hope it is, but we have to do the trial to actually prove that. And so, as I mentioned, our goal with this trial, which is a little bit of a departure design for us, is to evaluate this and answer as many questions in one trial as we can, to make it as efficient as we can, so that we know what to do with the next study. Because the next one is probably going to be the one that leads to its approval, right? But we don't want to just choose one path, find out it didn't work, and then lose time, or maybe even lose momentum and never have this done again, which happens a lot, you know. So our hope is by doing this smaller trial and answering multiple questions, we'll know the best way to take this forward and hopefully have a successful development plan for this combination in RA-refractory thyroid cancer and anaplastic thyroid cancer. So yeah, I'm happy to take any questions. So this first question, it says, for gene mutations in the pathway we talked about, where do TERT and DM3TA fall in line? Do mutations such as these impact your study? That's a really great question. So essentially, the mutations we care about are the ones I mentioned, right? So you can think about the acquisition of mutations in a tumor like branches on a tree, right? You have the trunk. The trunk for thyroid cancer are BRAF mutations, RAS mutations, RET mutations. Those are the ones that start the cancer off. And through the life of that cancer, whether it spreads to other places, those mutations will be present in every tumor. The branches off of that are these other mutations that are being referenced here, like TERT or DM3TA, PIK3CA, P53. They may make the cancers harder to treat or more aggressive. But in the end, even if those mutations are there, the hypothesis is because RAS and BRAF are the trunk of those tumors, if you have the drugs that inhibit that trunk, you can still kill those tumors, whether or not they have those mutations or not. That's the hypothesis. It's obviously a little bit more complicated than in anaplastic, et cetera, but that's the general hypothesis. So no, you can have TERT and DM3TA mutations as long as you have RAS mutations, the ones that we're looking for, okay? The second question is, do you also see a difference in response to dabrafenib, trametinib, be it for continuous use or for redifferentiation, depending on whether the patient had another TKI like lenvatinib? A very sophisticated question. Yes, so there was a trial. So generally speaking, we do think that there probably are differences in response depending on when you use it. The actual data is in with the BRAF inhibitor alone, not with the two drugs. But if you've had a TKI before, the response rate is probably a little bit less and the control time is a little bit shorter. That's not to say they don't work, they just don't work as well as when you use them first. At least that's what the minimal data we have now. We actually should do better and bigger trials to really definitively answer that question. But from what we know now, that's the case. For redifferentiation, it's the same issue. We have a little bit of data. It's hard to really make definitive conclusions. My opinion is that redifferentiation may be more challenging in people who have gotten other TKIs before. But the trial that we're doing here is really focused on more of these pre-treated patients. So we're really going to have a better idea in this trial about that question. So my guess is that it probably is true. It's harder to redifferentiate patients who have gotten lenvatinib before, but we don't know that for certain. Will you select for previous drug usage in the avutometinib defactinib trial? No. So one feature of this trial is that any prior lines of therapy are allowed. So yes, it doesn't matter what you've gotten before, as long as you haven't had a MEK inhibitor or a FAK inhibitor before. Yes.
Hi. So if you have an NRAS mutation and TERT and a bunch of others, like at least 3 or 4 others,
yeah,
but you're not papillary and you're not anaplastic, you're poorly differentiated.
Yeah.
Are you excluded from?
No.
Okay. Where do we fall?
I hate the fact. Yeah. So I do a lot. I use a lot of these acronyms for convenience. But when I say DTC in this framework, I'm really saying it non-anaplastic. So poorly differentiated is included in DTC. So yes, we are enrolling poorly differentiated in that particular trial. It is confusing because of the way I said it, but yes.
I don't know if my question is slightly off topic or on topic.
Yeah.
I'm just curious because everybody talks a lot about the BRAF negative. A BRAF mutation. I am BRAF negative.
Okay.
So maybe I just haven't had that explained enough to me.
Yeah.
But I was curious, if you're not a BRAF, does that mean you're above it, or can you not have a mutation?
Yeah. Okay. That is a very good question. We didn't have time to get totally into it.
You don't. If that's aside, we could.
No. This is important because it's actually a little bit more nuanced than even the way I just said it. All right. So there is a BRAF mutation that we call V600E. That's a single mutation. That's the most common mutation. So typically when people say, I have a BRAF mutation, what they're really saying is I have a V600E mutation. Typically when people say, well, I've been told I'm BRAF negative, what was really meant to be communicated is you don't have that mutation. Okay. The nuance is about 2 to 3%, about 3 to 5% of patients will have a BRAF mutation that is not V600E. That's a very rare subset, but they're biologically different, okay? So, but generally speaking, when they say, I have a mutation, it's that V600E. If you're negative, what they're saying is you don't have the BRAF mutation. Then the next question is, what mutation do you have? It's not mandatory that you have a MAP kinase mutation, I would say. So it's not mandatory you have another mutation. There is a small percentage of tumors where they don't have a RET mutation, they don't have a RAS mutation, they don't have a BRAF mutation, et cetera. There is that small percentage.
It's written, they're written in very doctor speak, so
Yeah.
it's hard to translate into
It is, yeah. So,
us.
but in over 70% of tumors, you'll have one of those mutations. Okay. Yeah, but you do have to kind of go through the report.
I was curious about this clinical trial because I'm doing a different one that is for my maybe lack of mutation.
Okay, well, that makes sense too, yeah. Okay, it says, regarding all MEK inhibitors having a risk of retinal detachment, as someone with history of retinal detachment, would you advise against using MEK inhibitors? Yeah, I think different people will have different answers to this. I typically, yes, avoid the MEK inhibitors in that situation, primarily because on the clinical trials where these things were evaluated, those patients were not included, you know, and I do think that there's a risk. Now, it is true that generally speaking, the retinal detachments for most of the patients that develop it on MEK inhibitors is reversible, but still, I get very antsy about that. So if I can, I avoid MEK inhibitors in that situation.
Hi, I'm Priyanka here from MD Anderson.
Hi.
I had a question.
Yeah.
I treat anaplastic thyroid cancer patients, and this trial is amazing, idea-wise. I was just wondering for the non-BRAF ATC patients, I mean, I understand you wouldn't take a trametinib, but sometimes we don't have a target. So a lot of times they're on either len-pembro or everolimus-pembro. What is your threshold, or will this trial allow patients who progress on these drugs to get on them?
Yeah,
And
we would allow that. Yeah.
because there's a washout period, I think you mentioned, of 4 weeks.
Well, the
Yeah.
4 weeks is only the cohort A. Actually, for anaplastic, we made it 2 weeks.
Okay.
So we shortened the washout period for radiation and chemo for the anaplastic cohort.
Okay, because
Yeah.
otherwise they'll progress
It
really
would,
badly.
it would not work.
Yeah,
otherwise.
that's what I was
Yes,
like,
exactly.
wait a minute.
Yeah, we have the same issue. So we've been treating the BRAF wild type anaplastic the same way with len-pembro,
Yeah,
and then we would transition to this.
okay,
Yeah.
thank you.
Is this also possible for MTC with RAS mutations? That is an excellent question. Yes. So there would be every reason to think that this might be effective against HRAS mutant medullary thyroid cancers, but in this particular trial, we're not testing that question. So because it also is a completely different disease and would have to be evaluated in a separate cohort. So maybe down the road, that's something that we should test. That's an excellent point. And then what is meant by dimer-driven? Okay, so I didn't get into this because this is a little bit in the weeds, the biologic weeds. And what that means basically is, remember I said the BRAF, even though all the genes are in the same pathway, the BRAF mutations are distinct or different from all the other ones. And the reason it's different is because BRAF can signal on its own when it's mutant. All the other ones require that the RAF be combined together, bound together, dimer. That's what dimer means. It's two together. And without getting into more detail than that, because of that, it has implications for how strongly the pathway is activated. Because BRAF can do it on its own, it activates the pathway much more strongly than the other dimer-driven mutations. It's also why the dimer-driven mutations may be a little bit more challenging to inhibit than BRAF. You have a narrower window to work with. But that's what dimer-driven. So dimer-driven is really referencing RAS mutations, NF1 mutations, RET mutations, TRAC mutations, et cetera.
Jay asks, might success in this trial give hope that FAK inhibitors might be added to BRAF and or MEK inhibitors to have greater efficacy?
This is crazy sophisticated questions today. Yes, that is exactly right. Yes. So, yeah, like I said, and a lot of this data is from, it has been done in cell lines. And a lot of it was centered in Rebecca Schweppes' lab here at University of Colorado, where they've been studying this for years and have really kind of pioneered this idea that FAK inhibitors and SRC inhibitors are really important to target in combination with all those MAP kinase inhibitors, right? So we came upon this indirectly because the company did this trial with ovarian, but this has existed with Rebecca's group for a while now. And yes, you could make the claim that combining FAK with a variety of these different inhibitors makes sense. We just have never tested it before. This would be the first test of that. It is true that that if this were positive, then you'd be anxious to maybe think about doing that. Now, the issue is, would it add more to dabrafenib, trametinib? It might actually, you know, because there are other reasons to think that it would add. So yes, an unanswered question. There's preclinical data to suggest that is the case, but no one's ever actually tested it. And then this says, what mutations do you see with liver mets? Is Cowden syndrome only driven by PTEN? Okay, another really good question. So remember that analogy of trunks on a tree that I was giving you applies to this, right? So that trunk in the tree, as I mentioned, is RAS and BRAF and all those other things. The other way to think about that trunk on the tree is sites of disease. So that trunk in the tree is your primary thyroid tumor. And then when that thyroid tumor spreads to different places, and maybe you have multiple tumors, you have a liver tumor, a bone tumor, a lung tumor, the fact of the matter is when you do the genetics on those different tumors, they may have different mutations, okay? But those truncal mutations should be present in each. So if you have a BRAF mutation that started in your thyroid and it spread to your liver, that liver will have the BRAF mutation. But it may have other mutations that your thyroid didn't have, like the TERT mutation we were talking about, or the or other mutations. Cowden syndrome is a genomic syndrome that's driven by PTEN loss that you inherit. So yes, that is the primary driver of those tumors, but that's not to say it's the only mutation. They can acquire other mutations to make them cancers. So
Okay.
it's the avutometinib has, we've done that extensively. We have not studied the combination extensively. So a lot of that is extrapolation from the ovarian data, what Rebecca has published. But the avutometinib we've done in anaplastic, we've done it in BRAF and HRAS, anaplastic, poorly differentiated models. And as I mentioned before, regardless of what parameter you look at, it inhibits the pathway the strongest and gives you the best outcomes in the animals. Yeah.
Is this a phase 2 trial? Can you tell us anything about the phase 1?
Yeah, so this is a phase 2 trial. So all that means is, so phase 1 is usually for drugs that haven't been tested in humans before, combinations that have never been tested in humans before. This is well past that now. So it did the phase 1 and had done phase 2 trials. And phase 2 trials are really meant to say, okay, how well does this work? And are there promising signals of activity to take to phase 3 and get them approved? So this is about finding signals of activity. So the phase 1 found this combination to be safe. The phase 2s in ovarian showed the combination was better than the single drug alone. And that's why we're doing this in thyroid cancer. That does remind me, I was supposed to also mention International Thyroid Oncology Group, which was the driver for a lot of the trials that we did, which is a consortium of academic centers, not only here in the US, but also in Europe and internationally, working together to develop thyroid cancer trials, just to acknowledge that. And it was really driven by advocacy from different academic centers, but really started by a patient who had thyroid cancer. So it really shows the power of patients' involvement in research and not only participating in trials, obviously, but driving those research outcomes. And this organization is an important part of that. Thank you.
Thank you very much.